Well, hello and welcome to yet another 15 on COVID-19 episode brought to you by the American Pharmacist Association. I'm your host, Dan Zlott, Vice President of Education here at APHA, and today we will be talking again about Remdesivir, except this time, finally, we'll be talking about some randomized controlled trial data. Well, it's very exciting. It's one of the few times when we've been able to do this in the COVID-19 experience. So let's go ahead and jump right in. As usual, I have nothing to disclose. Here are your learning objectives for today's episode. All right, well, let's just go ahead and review some of the background before we jump into the trial we'll be reviewing today. On April 27th, the National Institutes of Health issued a press release which stated that in a randomized placebo-controlled trial of Remdesivir, they found a statistically significant improvement in time to recovery. So the time to recovery was decreased by approximately 4 days as compared to placebo, and a strong trend towards decreased mortality as compared to placebo. And if you recall from one of our previous episodes, they just barely missed statistical significance on this. I think it was 0.056 or 0.054 if memory serves. So very narrowly missed statistical significance on the trend towards decreased mortality with Remdesivir. Now, at the time of that press release, the full study write-up wasn't available. However, the FDA granted an emergency use authorization for Remdesivir for the treatment of COVID-19 on May 1st. So clearly there was some positive data there. But now that we have the full trial data available, we can actually dig in and evaluate the study design ourselves. So that's what we'll be doing today. So the trial itself was called the Adaptive COVID-19 Treatment Trial, or the ACT-1 trial, and it was a multi-center, multinational, randomized, double-blind, placebo-controlled trial. Involved 60 trial sites across a number of continents. We've got some of the countries who participated listed there for you. And enrollment began in late February, February 21st to be exact, and ended on April 19th. Now, the data that we'll be talking about today is based on the interim analysis that was conducted on April 27th. So the trial itself was not fully completed. In the case of this study, they actually still had patients who were in process. They hadn't reached the 29-day mark, and they hadn't met any one of the endpoints that were specified, but they had enough data that they decided to do an interim analysis. So that's sort of where we're at. The trial is not, the data from this trial at least has not fully matured. So I would expect to see an update at some point down the road. So let's dive into their methods. So patients were enrolled in a one-to-one fashion between Remdesivir and placebo. And patients were stratified by study site and disease severity at enrollment. So again, the whole idea of stratification is to ensure that there's an equal number of patients with the characteristics that you're stratifying by, to ensure that there's basically, you're trying to minimize confounding variables. The intervention that was looked at was, as we've discussed before, Remdesivir 200 milligrams intravenously on day 1, followed by 100 milligrams intravenously on days 2 through 10, or until hospital discharge or death. So a total of 10 days of therapy was the full course of therapy. And they used a matching placebo, and that was given according to the same schedule, with the exception of some sites in Europe where a matching placebo was not available. And so what they used instead were saline infusions, and they masked those with opaque bags and IV tubing covers so that neither the staff nor the patients could tell what was being infused. That's a pretty common practice. We used to do that a lot at the National Institutes of Health when I was there. So who were the patients in terms of the inclusion-exclusion criteria? The inclusion criteria, patients had to be 18 years old or older. They had to be COVID-19 positive by PCR assay. And there was a little bit of a change in what was considered to be allowed for that. So initially, they had to have a specimen that was collected within 72 hours of randomization, and they found that was a little bit difficult and was basically resulting in resampling of patients who had samples available. And so they later modified this to allow for specimens to be collected more than 72 hours prior to randomization. They also had to have symptoms suggestive of lower respiratory tract infection, and that included lung infiltrates, a pulse ox of less than or equal to 94% on room air, or if the patient required supplemental oxygenation, or if they required mechanical ventilation, or if they required ECMO. So any of those qualified as symptoms suggestive of lower respiratory tract infection. Patients could have no other investigational COVID-19 treatment until day 29 post-randomization. So they had to agree to that condition in order to participate. And then they also had to agree to use contraception through day 29 for women or partners of childbearing potential. All right, so let's continue on with the exclusion criteria. So the first exclusion criteria were patients who had an AST/ALT greater than 5 times upper limit of normal. And you may recall that in past trials with Remdesivir, we know that liver function test abnormality is one of the side effects that you can see with Remdesivir. So it makes sense to exclude those patients. Patients who had impaired renal function, whether that was by eGFR estimation or because they required hemodialysis or hemofiltration. Either of those were exclusion criteria. Patients who are allergic to the study product. Patients who are pregnant or breastfeeding because of the unknown impact of Remdesivir on the fetus and or small children in the event that it's passed through breast milk. Anticipated discharge or transfer to another hospital within 72 hours. That makes it difficult to follow up with the patients. And then patients who received other investigational COVID-19 therapies were also excluded. Now, there's a special condition, which is that if institutions had a standard policy or guideline for the use of other treatments, not investigational treatments, so not that there's such a thing as a standard treatment for COVID-19, but if your hospital had a standard approach to treating treating COVID-19 that did not involve an investigational agent, that was not considered an exclusion criteria. So it's a little bit confusing there. And a potential confounder we'll talk about at the end. So what were some of the outcomes that they were looking at? Well, the primary outcome was time to recovery. And that was defined as the time from randomization to the first day during which the patient was a category 1, 2, or 3, according to the ordinal scale that we've seen before. And so just to review it really quickly, 1 is a patient who's not hospitalized and has no restrictions. 2 is a patient who's not hospitalized, has some limitations on activity, or who requires home O2 therapy. 3 is a patient who's hospitalized but does not require supplemental oxygenation and does not require ongoing medical care. Essentially, those patients were hospitalized for infection control purposes rather than for medical care purposes. 4 was a patient who was hospitalized who didn't require supplemental oxygenation, however, did require some level of general medical care. A 5 was a patient who was hospitalized who required supplemental O2, usually by typical nasal cannula. A 6 was a patient who was hospitalized requiring non-invasive mechanical ventilation or high-flow oxygenation. A 7 was a patient who was hospitalized requiring invasive mechanical ventilation or ECMO, extracorporeal membrane oxygenation, and an 8 was a patient who had died. So that's the scale, and we'll come back to that a couple times as we discuss the study. Continuing on with outcomes, moving on to the secondary outcomes, they had mortality, grade 3 and 4 adverse events, as well as serious adverse events, so you can see a focus on safety data there. And then the last secondary outcome was improvement in clinical status. Now this was interesting. It turns out this was actually their original primary endpoint, and it was changed to a secondary outcome. And when that happens, that almost always raises red flags about the quality of a study. However, the authors give some reasons why this happened, and so they say that this was proposed by trial statisticians who had no knowledge of the treatment assignments or outcomes data, so the people who were making the proposal were completely blinded. And the reason for the change was because of new data that was coming out about COVID-19, essentially that the course of the disease was more protracted. It took longer to recover than they originally thought. And so as we go throughout the study, you've already seen that they talk about the course through day 28 or day 29. And when patients are taking a long time to recover, if your primary endpoint is improvement in clinical status over 28 days, that may or may not reflect the true course of COVID-19 and whether or not that's a realistic expectation. So that's supposedly why they made the change. And I say supposedly because we know for sure that the primary endpoint changed. And as I said, that's always a red flag. This makes logical sense for why you might change an endpoint. However, you have to take them at their word that that was the reason why they changed the endpoint. And to further build their defense as to why they changed the endpoint, they then go on to say at the time of the amendment, only 72 patients had been enrolled, so that's out of over 1,000 patients in this study, and there was no interim data available. So what they're trying to say is that it wasn't as if they were going through the trial, looking at the data and saying, oh, hey folks, we have a problem here. We're not going to meet our primary endpoint. Let's make that a secondary endpoint and maybe find another primary endpoint that we think we can meet. That happens from time to time, unfortunately, and that is the reason why when you see endpoints change, that's always a red flag. So they're trying to say, hey, we didn't do that here. That's not what happened. We were actually looking at the disease, and we felt we needed to update the primary endpoint because of what we learned about COVID-19. So whether or not we take them at their word, it's a judgment call. We do have to take them at their word. One thing that's always an indicator is if the rest of the study was conducted in a very rigorous, high quality fashion. Personally, I'm more likely to give them a little bit of wiggle room on a statement like that than I would be if there were other major flaws. So let's go ahead and apply some significant scrutiny in the rest of the trial and see if we find other glaring issues or if they really tried to do things right. And we can come back to this and decide if this is a major issue or not. So continuing on with outcomes, the pre-specified subgroup analyses were based on sex, disease severity, age group, and they've got 3 different categories there, and then whether the duration of symptoms prior to randomization were less than or more than 10 days. Now they get some points here because they pre-specified their subgroup analyses. So they're telling us in advance, these are the groups we want to look at. We think there may be some differences in outcomes based on these things, and so we're going to do some additional exploration. The reason that's important, you may have heard in previous episodes, I like to use the analogy of a dartboard, and the difference is, do you have the dartboard hanging on the wall first and then you throw the darts at it? That's the equivalent of having pre-specified analyses. So you're saying, this is what we want to hit, and then we're going to throw darts and see how we do. Alternatively, the other way to do it is to throw darts first and then draw dartboards around where the darts land. And when you do that, it's easy to find correlations that are statistically significant when you do subgroup analyses post hoc. Or in other words, things that are not predefined. And when that happens, you're very much limited to those things only being hypothesis generating. So there's a correlation, but as always, correlation does not equal causation. With pre-specified subgroup analyses, it just lends some additional credence to the validity of their subgroup analyses. So at the time of interim analysis, there were 391 patients in the remdesivir arm and 340 patients in the placebo group who had completed the trial through day 29, who had recovered or who had died. So they're just kind of telling us these are all the folks who made it all the way through and we have really complete data for them. The remainder are folks who we have some data but not complete data. So they're doing their best to ensure that we know exactly where people are at in terms of data maturity throughout the trial. So that's helpful for us. In terms of the randomization, there were 1,063 patients randomized, 541 to the remdesivir arm, and 522 to the placebo arm. Of the patients randomized to the remdesivir arm, 531 patients actually received remdesivir. 10 patients did not, and that's because 3 patients did not meet eligibility criteria. So they made it through the initial screening and were randomized, but they should not have been. They didn't actually meet eligibility criteria, so there was a investigator error. And then there were 7 patients who withdrew consent. And on the placebo arm side, there were 518 patients who received placebo and 4 patients who did not. Again, 1 patient who did not meet eligibility criteria and 3 patients who withdrew consent. So this figure, before we get into more of the results, they do a very, very nice job in this figure of helping us follow each and every patient and the path they took throughout the trial. So they're telling us exactly what happened when patients had issues, when they were lost to follow-up, patients who were excluded because they didn't have baseline data. All of that information is included. So to me, this is what I look for in a high quality paper. When you can account for each and every patient that was included or screened in a trial, the investigators have done a nice job of tracking the data. So they get a thumbs up for this. So let's talk some more about the results. The analysis population, so they randomized 1,063 patients, and they're saying they were only able to analyze 1,059. So there's obviously 4 patients missing. And they included in their analysis population everybody who had at least some post-baseline data available. So you had to have baseline to be eligible, and then you also had to have some additional post-baseline data in order to be included in the analysis. So this is not a true intention to treat analysis. However, again, they're doing everything they can to help us track every patient and their flow throughout the trial. So again, great comfort there in terms of the quality of the data. There were 538 patients analyzed in the remdesivir group and 521 in the placebo group. 4 patients were excluded, 3 patients in the remdesivir and 1 patient in the placebo group, again because there was no data available after their baseline data was collected. So let's take a quick look at who the actual patients were in the study. So here are some of the baseline characteristics, their age, the male-female ratio, the time from symptom onset to randomization, number of comorbidities, types of comorbidities. There were, of course, more, but these are just the top 3 for you, and then the baseline disease severity. So the important thing to know is that there were no statistically significant differences in these characteristics or others between the remdesivir arm and the placebo arm. So very equal randomization. All right, well, let's get into the actual outcomes that we're looking at. In terms of the primary outcome, time to recovery, the overall time to recovery was 11 days in the remdesivir arm as compared to 15 days in the placebo arm. That was statistically significant with a p-value of less than 0.001. In terms of clinical improvement, which was the original primary outcome that turned into the secondary outcome, the odds ratio for improvement at day 15 was 1.5. So in other words, at day 15, you were 1.5 times more likely to have shown clinical improvement if you received remdesivir as compared to if you received placebo. The magic number here, because this is an odds ratio, is 1. And so when you look at the 95% confidence interval, you see that it does not cross 1 and therefore is statistically significant. And just to drive the point home, they were nice enough to give us a p-value there, 0.001. So this was highly statistically significant. Moving on to look at mortality, we will see that it does not quite reach statistical significance. So the hazard ratio for death was 0.7. So if you received remdesivir, you were 0.7 times as likely to die as compared to placebo. So that's a benefit for remdesivir. However, because this is a hazard ratio, the magic number here is 1, and looking at the 95% confidence interval, as you can see, it definitely crosses 1 and therefore just misses statistical significance. They also looked at mortality rates at day 14 and found again a strong trend towards improvement for remdesivir, but it was not statistically significant. So now looking at safety outcomes. In terms of serious adverse events, there were 114 serious adverse events in the remdesivir arm and 141 patients with serious adverse events in the placebo arm. And in each group, 2 events were judged to be related to either remdesivir or placebo, depending on the group. And in a clinical trial like this, it's actually up to the investigator to assign whether or not the SAE, the serious adverse event, was due to the intervention or whether it was due to other factors such as disease progression. And so in each case, there were 2 events judged to be related to the intervention. There were 28 respiratory failure events in the remdesivir arm as compared to 42 respiratory failure events in the placebo arm. Looking at grade 3 or 4 adverse events, 156 patients or 28.8% in the remdesivir arm had grade 3 or 4 adverse events as compared to 172 patients or 33% in the placebo arm. Now, it might seem odd on its face that patients receiving placebo had more grade 3 or 4 adverse events. However, keep in mind that not all adverse events are drug-related. So when you're doing a trial, you have to record all adverse events regardless of what the cause of the adverse event was. So if you have a situation where your intervention, or your remdesivir in this case, is more effective than placebo, it's not unheard of to have more grade 3 or 4 adverse events in the placebo arm as compared to your intervention arm. And that's likely what we're seeing here. And so they have a breakdown of anemia, decreased hemoglobin in the two groups, acute kidney injury, hyperglycemia, and finally increased AST/ALT. Now, interestingly, for a drug that's somewhat known for having some hepatotoxicity, the incidence of increased AST/ALT in the remdesivir arm was actually lower than what you saw in the placebo arm. So kind of interesting. I think that probably is related to the fact that in COVID-19, we do know that on autopsies, there is some hepatic involvement of COVID-19. So you can actually find evidence of hepatic damage, either because of direct viral infection or because of a hyperactive immune response against the virus in the liver. So that's, I'm hypothesizing, so I want to make it clear that's a hypothesis on my part. That is not proven fact. I'm just trying to understand why you might see increased AST/ALT adverse events in a placebo group as compared to in the remdesivir arm. So let's move on. So what were some of the limitations of this study? Well, first and foremost was the primary endpoint that changed mid-trial. So as I mentioned, that's always a red flag, always a red flag. And so, you know, if we're keeping score, they lose some points for changing their primary outcome. However, the change was recommended by people with no knowledge of the outcomes, and no data had been analyzed at the point that they made the change. Additionally, when you look at the quality of the rest of the trial, they did a phenomenal job of tracking where every patient was and making sure that we, as the analyzer of their study, analyzer of the data, were able to follow along with them where each patient was at, where they dropped out, what happened at each step. So on the whole, this was a very high quality study. And so even though that's a limitation, I would take away less points than I would otherwise because of the fact that they went out of their way to make this such a high quality study. So that's my assessment. You, of course, are free to make a different assessment. Patients were allowed to receive other therapies for COVID-19. So that's another limitation of the study. I think we mentioned earlier on that if a hospital had a protocol that they gave, for example, lopinavir, ritonavir, just as standard of care for COVID-19, patients were allowed to receive that. That wasn't considered investigational. And so that's a potential detractor. It's difficult to fully assess the impact of that. However, one would presume that in the course of randomization, that equaled out, and so there were equal numbers of patients in each group who received those other therapies. However, the authors don't report on that, so we really don't know whether that was the case or not. And I looked through the supplementary materials as well and was unable to find that data. So maybe when the full report is published, they'll provide that information, but for now, we don't have that information. So that is one limitation to the study that I was able to identify. And the last thing is that this is an interim analysis. That's not really a limitation per se, but we do have to realize that as the data mature, some of the outcomes we saw here may change, either in favor of remdesivir or against. So this is not the final word, and we'll have to wait a little bit longer to get the true final word. However, things look pretty good. So let's get to the bottom line. So clearly this was a very well-designed study. They really did a great job of making sure that we had all the information we needed to track patients as they went throughout the study. The study clearly demonstrates improved time to recovery with remdesivir. Again, there's a strong trend towards improved survival that may, as the data mature, become statistically significant, but we'll have to wait. Only time will tell on that. So truly, the bottom line, we can finally conclude with confidence that remdesivir improves outcomes in patients with COVID-19 and for the time being should be the standard of care for hospitalized patients with COVID-19. So that will wrap up today's 15 on COVID-19 episode. We are very excited to announce that on Friday, June 12th, we will have our first guest host here on the 15 on 19 series, and we will be talking about telehealth, and we will be hearing from probably the most informed pharmacist on the topic of telehealth that I've ever come across, and that's Sandra Leal. So we are so excited about that. We hope you'll join us on Friday. Until then, if you have any questions, please keep them coming our way. We continue to get some great questions about COVID-19, and we look forward to working with you to answer those questions. Thank you once again. We hope to see you on Friday.